Good afternoon, everyone. Welcome to the July meeting of the RCORP-ETC. For those of you who are new to our group, I just wanted to give you a special welcome in hopes that you will continue to join us on a quarterly basis for these meetings and take some advantage of the other resources that we have. With that, what we're seeing here is our website. And you could access this at tnopioid.utk.edu. And this month we have the special feature of our quarterly newsletter that has come out. You can see the advertisement for today's great event. But you can also see that we have another event coming up on August 18th. This is a youth development training. In order to enhance prevention, we are, with the RCORP-ETC, very interested in promoting empowerment and skill development of young people to make a successful transition to adulthood. And with this one, the emphasis is going to be on promoting emotional safety when working with young people. So we invite you to register for this. You can find it on our newsletter, which, as I showed you, you can access on the very front page. And Audia, our fantastic graduate student who is with the College of Social Work, will be leading this event. So again, August 18th. While we are doing the presentations today, I invite you to turn your audio off. If you are not your audio, turn your video off if you are not presenting, simply to assist with bandwidth, because not all persons who are attending today have a strong internet connection, and that will help everybody out. Please keep yourself muted unless you are talking. And if you would like, if you go to the upper right hand of your Zoom screen, you can select speaker presentation, and this way you'll get the person who's talking picture next to their screen share, which makes for a really focused way of sharing the presentation and being an attentive audience member. So with this, I'm going to be turning it over to my incredible colleague, Dr. Jennifer Torville, who is the co-director of Project Now, which is one of our grants that is funded through HRSA with the RCORP-ETC. Jennifer?
Hi, thank you, Lori. If you will stop sharing your screen, I will share mine. Thank you. So we're going to be talking about hub and spoke model today, but we wanted to just give you a little bit of information about a program through HRSA, the Health Resources and Services Administration National Health Service Corps. So this is a program that's actually been around for a little while, but they are expanding the services that they provide. So it's to increase providers in rural areas that don't have great access to healthcare. So you can become a site, you have to meet some criteria. And basically what it does is it will repay student loans for providers, primary care, dental, mental health, and now substance use disorder providers. And it covers 2 to 3 years of their student loans. So it repays their student loans in exchange for them providing services in rural areas. So for a clinic to become a site, they have to meet some criteria, and they base the criteria on a score, and that is calculated through their population to provider ratio, the percentage of the population below the federal poverty line, and the travel time to the nearest source of care. So this is how the scoring, and we're not going to go through all of this, but I wanted to show you, and we can share this presentation to our website, and it has the link at the bottom, so you can do some calculations if your practice might be considered a site and you want to apply for healthcare providers. So primary care, mental health, dental, you have to get a score of 20 to receive a primary care physician or a primary care nurse practitioner. 14, you can get a physician assistant, or 10, then you are eligible for a nurse midwife. Mental health and dental, you have to have a score of 20 to receive either of those providers. And then this is just kind of showing all of the programs. They have expanded it to include a substance use disorder workforce loan repayment program, which is 3 years. You can see there in the middle what it pays, up to 100K, up to 75 for the different programs. They also have counselors. So master's level counselors will also qualify for the substance use disorder workforce program. They did this last year for the first time. We're hoping that this will be a continuation with all of the other programs that they have. So these are some resources for more information about how to apply. Honestly, it's a little cumbersome and it is a complicated process. If you are interested in possibly applying or want some more information and not have to go through all of these resources, we will post this on our website, but we will also be happy to help you walk through some of that. So reach out to us if you're considering it. I'm going to stop sharing my screen. We have with us today Deborah Chumley. So she's going to talk to you about their experience with this program. She's the co-CEO and Chief Operating Officer for Servolution Health Services in Claiborne County. They have multiple providers that are employed through the HRSA NHSC program. She's going to briefly share just some of the information with us and their experience with the program. I'll put the link to Servolution's website in the chat, just so you can look up the services that they have if you'd like to. Deborah?
Good afternoon, everybody. This has been a very beneficial program for us because we started out as a free clinic and had volunteer dental services, and that was just not working for the population that we serve. And so we went through the application process to be at a site, and our dentist, we were expecting a long wait, but we had him within a few months, and that's just been such a boost for our area. If anyone's interested in actually applying, the first thing that you would need to do is to see if the area that you live in or that the agency is in a medically underserved area or a HPSA designation, and that is a health shortage professional area. And so those scores are what, if you don't have a score within the range that she had mentioned previously, then you're not even able to apply. So that's the first thing that you would need to do. And going through the process doesn't guarantee that you have someone immediately. We were just very fortunate that we were able to get a dentist, but it's definitely worth the time. If you're going to apply, you need to have all of your data for your agency, as how many patients that you have, how many patients are under that poverty level, how many that you, in our case, that were insured versus uninsured, and so forth. You have to have all that data, and you have to have a sliding scale fee determined to send in with your application. So that was something that we didn't have, that we had to develop. Now, those things can be changed when you get in the process and you see that maybe they're not working, but that's something that you need to do prior to. And also you can, when you become a site, that does not guarantee also that someone that comes to your agency can automatically, get the loan repayment. They have to go through an application process as well. And so you can't guarantee that has to be a HRSA designation or a HRSA approval that they can be placed at a certain location. And when we got our dentist, Dr. Meister, he had to have a score of 19 at that time to be placed somewhere. And so we were able to fit that criteria for him. There's actually two different processes. He went through and they paid for his tuition throughout school, and now he's getting the loan repayment. We have two providers that have been out of school for a while but still had debt, and so they were able to apply in a kind of a different vein, and so it pays on debt that they had already occurred. So it's a good thing for them too. We have one that's working part-time and two that are full-time. you can only have one provider in each designation. You can only have one dentist or one doctor, one nurse practitioner, and so forth. So it's, like I say, it's been a very beneficial program for us. Jennifer, I sent you some links. I emailed them to you. And in that is the HRSA Bureau of Health Workforce Division of Regional Operations. At the time that we did the process, Lisa Gilmore was our contact, and she was great. She kind of walked through the process with us. And I'm not sure if she's still there, but that regional operation office is there. So I sent that to you, the phone number and everything as well. So that's kind of everything in a nutshell. Is there anything else that I need to add there?
I think that was great, Deborah. We really appreciate you sharing a little bit of insight about the program. It is a little complicated, but once you get it up and running, it really is very valuable for our rural community. So if anybody's interested in your area, Lori, do you have a question? I see your hand is up.
Yeah, I was just curious, is there a renewal process, or once you get this certification and you have the program initiated, does it just continue, Deborah, or what do you have to do?
We've not gone through a renewal yet. It's every 3 years. And so we're actually in our 3rd year. So we'll be going through that a little bit later. It's due in December. But yes, at this point, it's every 3 years.
And you wouldn't expect there to be any gap between the renewal and in your current status?
No. I think it's just, I say renewal, but I think it's more of an update. You know, and because we have to, every 6 months, I have to do a report on the 3 that we have, and, you know, put their hours in and that they're here, and certify the time that they've spent. So that's done every 6 months. And then the update to renew contract or whatever. And if there's any changes in HPSA scores or anything like that, that has to be adjusted as well. So.
Thank you so much. I'm so glad you had that opportunity and it's working out so well.
Thank you.
All right. Thank you, Deborah. Now we'll move on to the hub and spoke part of the presentations. So our first speaker is going to be Dr. John Brooklyn, who's a clinical associate professor of family medicine and psychiatry for the Larner College of Medicine and a clinical expert for the Center of Rural Addiction at the University of Vermont. Dr. Brooklyn also serves as the medical director for multiple clinics. He's been a strong advocate for people with substance use disorders to be integrated into medical homes and conceived of the internationally recognized Vermont hub and spoke model. He helped create CHARM, which is an integrated nationally recognized model to treat pregnant women with opioid use disorder and their children. He currently expanding access to MOUD with a smartphone video app and medication dispensers. Dr. Brooklyn's presentation is titled The Critical Role of Hub and Spoke in Increasing Access to Care. Dr. Brooklyn.
Thank you, Jennifer. I appreciate it. Good afternoon, everybody. Hopefully you're staying cool during this time of year and enjoying yourselves. I know what Jennifer said sounds busy, but really I'm a family practice doctor who also does addiction medicine on pretty much a daily basis. And so what I'd like to talk with you about today is a way of thinking about treating opioid use disorder in a more community and systems-based way. Last year, as you know, over 100,000 people in the United States died of opioid overdose, which was equal to that of diabetes. And we often don't think about that because we take care of diabetes day in, day out. But really, we're talking about a very fatal disease in the fentanyl era. And so I think sometimes when you begin to think of it as more than harm reduction, but death prevention, perhaps there's a different way to approach how we take care of people with opioid use disorder. Now, if you're like me, when you think of Vermont, you probably think, it's a pretty place. Gosh, I've got to get this thing to advance. And we often like you to think about Vermont in this way. And I know Tennessee probably looks like this in the fall time. But Vermont actually was very late to the game in terms of treating opioid use disorder. We're now just 20 years from the opening of the first methadone clinic, and buprenorphine, for many of you who don't know, was FDA approved and released in 2003. So we're really looking at about 20 years of our Vermont experience. And for much of that time, it was business as usual. We actually had research at University of Vermont on buprenorphine. So many of the community providers were familiar with buprenorphine, so that when the waiver training became available, we had a certain cohort around the state that took it on. And for a long time, we had about 3 times as many people on buprenorphine as on methadone. As a family doctor, I was using it at my federally qualified health center almost immediately. And I convinced some of my colleagues to become waivered and prescribers. And what I began to notice was that over time, many people became very stable, but some patients, as many of us know, were difficult to take care of. Maybe they were ongoing heroin use at the time. Maybe they were using stimulants like cocaine, methamphetamine. They were drinking alcohol. And back in the 2000s, a lot of times people would just discharge people from treatment. And so what you have is you have somebody with a potentially fatal disease losing their treatment provider. And I think it was mainly because the providers were not skilled in taking care of people with addictive disorders. So I thought about it and I thought, I'm also running a methadone clinic, and why couldn't I take some of these folks? But there was no linkage, no coordination. And so the idea of creating an integrated system of care, just like we do in all the other aspects of medicine, made sense to me. Because as I mentioned, diabetes, if I have someone whose hemoglobin A1C is 14 and they're having renal problems, I may have them see an endocrinologist to kind of help them get stable, or maybe there's a complex regimen. I wouldn't stop taking care of them. I would have a referral network. So I really envisioned a referral network where the specialist, i.e. the addiction specialist at the methadone clinics, would be able to assist the local providers, the buprenorphine providers, and perhaps take on some of those cases or help with those cases so that they could refer people back and forth and not necessarily discharge someone. And as many of you know, in the world of opioid treatment programs or methadone clinics really are standalone. Many people that go there are siloed from care. They don't have primary care. Many providers of these folks don't know they're in methadone programs. And you have this situation where there's not communication. So in essence, the hub and spoke really is trying to integrate the treatment of opioid use disorder into primary care and providing a referral network so there's no loss of treatment. It's not stealing patients from one another. It's not trying to, keep people from getting the care that they need, but it's actually creating a structure with which people can move back and forth. And so we call our opioid treatment programs hubs, in which they can get methadone, buprenorphine, and naltrexone. And we call our office-based opioid treatment program spokes, where they can get buprenorphine and naltrexone. I'm having a hard time regulating this thing here. And the model really was designed to increase the number of opioid treatment programs. When the hub and spoke was proposed in 2011, we had 5 opioid treatment programs scattered throughout the state. And before we started this talk today, I was asking the panel members, like in your area, I think there's 5 counties that are involved, and you have Knoxville in the center there. It could be quite a ways that someone would have to travel to get to a methadone program. And that situation still exists in Vermont. We have some programs located in very rural communities, 3,000, 5,000 people in little shire towns. But there are some people that can travel over an hour to get there. So I completely recognize that I'm talking to a group of people in a rural setting that's very similar to the situation we had in Vermont. And so the question is, how do you add capacity? And then how do you get enough buprenorphine prescribers so that you can create this system whereby they're linked? So this is just a busy slide, but essentially when the program was set up, there was money that was drawn down from the Affordable Care Act that allowed for the hub and spoke model to be predicated on a medical home model, or community health teams. So these hubs were established as centers of excellence. The spokes were established as primary care. There was a certain amount of resources that was provided called the health home resources, and we'll talk more about that in a minute, so that people could go where they needed to go, but there were additional services that were provided so better care could be provided. And so you created these OTPs, these OBOTs, and really trying to ultimately get people to primary medical homes and increase the number of people getting medical care. Because for a lot of people, when they come into treatment for opioid use disorder at say a methadone program, or they want buprenorphine, say from a specialty program, they still don't have access to primary care. And many of them have high blood pressure, they smoke, they have hepatitis C, they have mental health issues, they have asthma. And so getting those all treated under one roof was really the goal. And so a lot of the primary care providers became buprenorphine waivered so that people could receive care under one roof. A hub basically is at the center of it all. You can get referrals from anywhere. We have many people who come to us from the criminal justice system in Vermont. I'll talk about that in a few minutes, but there's no wrong door in. So if someone starts at a spoke and they don't do very well, they can go to a hub. If someone starts at a hub and they do well and they're on buprenorphine and naltrexone, we'll transfer them to a spoke. And so there's this bi-directional connection. So I like to say Vermont is like Tennessee stood up. It's long and slender. We have these red circles represent where the hubs are in the state. You can see up here in the far northeastern corner, there's a lot of distance here that people may have to travel. And we do have people that travel over an hour, but the idea was to try to get enough hub placements, enough OTPs, so that people wouldn't have more than a 35-minute drive. Not necessarily the case, but that's the goal. So for instance, for this hub here in the purple Windsor, all the spokes, all the OBOTs, all the primary care providers, if they needed to make a referral, they'd either refer to this one, or if they were close to this one, they would refer to this one. So we tried to link within counties the programs that already existed. You wouldn't want to have somebody who's living up here who's getting buprenorphine referred down here to this hub. It's much too far. So the idea was locating these where they were most needed. And then the other component that is very important to mention is that in the spokes, as we know, those of us who provide buprenorphine treatment to people with opioid use disorder, it can be fairly complex. And a lot of providers aren't addiction trained, and they may not have the same level of comfort with people who are using cannabis or alcohol, especially when it comes to stimulants, methamphetamine, cocaine, because we don't have any treatment for that. And so we wanted to create a situation where it was a team-based care. So we have this model in Vermont called the Blueprint for Health, which oversees all medical care delivered. And they designated opioid use disorder as a chronic disease, just like diabetes or congestive heart failure. And so we were able to draw down funding to create these MAT teams, medication assisted treatment teams. And they were composed of two people. One was a full-time registered nurse, and one was a full-time master's level clinician, either a licensed alcohol and drug counselor or a behavioralist or a social worker for every 100 buprenorphine patients. So what happens is they'd be deployed to the practices at no cost. So if you're a primary care provider and you have 40 buprenorphine patients, you would get 0.4 FTE of time. And these folks could be either co-located in your office or could do a lot of the work remotely or virtually by meeting people, visiting people, perhaps coming to your office. But they were really the glue that held this together, because if I'm seeing somebody for 15 minutes and they've got another 167 and a half hours of their week where things could go wrong for them, they can make contact with one of these providers for, say, some brief intervention, help with getting their driver's license back, dealing with housing, whatever the case may be. All the different issues that come to mind are dealt with by both of these individuals, again, at no cost to the practice, paid for by the Blueprint. And I recognize that Tennessee is not a Medicaid expansion state, and many states across the country are not Medicaid expansion, but they have adopted this model through different funding. But the fact remains that having this team-based care allows providers to provide better care than they ordinarily would. And I'll show you some stats in just a second. Now, I'm biased. I think federally qualified health centers are ideal for treating substance use disorder. I don't really know the landscape although I understand there are not many FQHCs, perhaps in the RCOR area, maybe I misunderstood that. But the reason I think it's important is that they have an underserved population they typically take care of, they get cost-based reimbursement, and also they have behavioral health on site, and that can make a big difference. The 6 core services that are provided in which you're able to draw down funding are these. And basically, either the spoke staff or the hub staff would provide one of these and be able to get some additional funding for those services provided. We also developed a tool called the Treatment Need Questionnaire. It was made of 21 questions that we would use in emergency departments or when someone came into your office. And it was really a screening tool to determine whether or not you thought that person was appropriate for the spoke or the hub. And the higher the score, the more likely you were to need a hub, and the lower the score, a spoke. I'll share these slides later, but essentially the big ones that we always focused on were the top 6 here, which is that history of intravenous use, if they've ever been in treatment before, do they have chronic pain, do they have problems with alcohol, cocaine, or benzodiazepines. Those were the 6 items that we found in the literature were the most likely to predict poorer outcomes. And so they were weighed as a score of 2, and the rest were weighed as a score of 1. But we recognize in a very rural environment that someone may have a high score but have nowhere to go except an office-based program. And so we would take them and do the best we could, but we would also know that there were challenges we might have to meet. So the other piece that's critical for this, and I don't know if you're doing this now, but it would be a great thing, is what we call learning collaborative, because as you know, when you take the waiver training, although you don't even need to take the waiver training anymore to be able to prescribe, you really just get the basics. And we know that there's many things that providers can learn about taking care of complex issues. There's things such as urine screening, or what do you do for people who can't sleep well, or people who have post-traumatic stress disorder. So the Learning Collaborative picked many topics, and on a quarterly basis, we would have either webinars or in-person events. And then the MAT teams would come and they would share like how they approached a variety of problems. So it was really collaborative and made a huge difference for a lot of providers. In 2017, we eliminated the wait list in the state of Vermont for opioid treatment by having all the hubs able to take people on demand. And so this slide shows from 2013 at the initiation of the hub and spoke model until 2019, the growth over time. You can see here that when it first started out, there were about 1,800 people who on Medicaid served in the spokes. And then 6 years later, that practically doubled. The number of spoke providers was really big in terms of over doubling from 114 to 260. But the other key metric that we used is that for most providers in the United States, they treat less than 10 buprenorphine patients. In fact, some never even dust off their waiver. And so we're trying to find out if we gave MAT teams, if the number of providers who treated more than 10 would increase. And we saw a doubling over that 6-year period from 38 to 74. And then MAT stat increased tenfold. So that's really important in terms of thinking about how things expanded through the hub and spoke. The number of people treated in the spokes rose dramatically. At the time, we had somewhere all payers of about 3,500, and now we have about 10,000 that are currently in treatment as I speak today. So another slide illustrating that. And then just a couple other things before I move on. And that's just to show that in the state of Vermont, we currently, based on NISDA, National Survey of Drug Using Households, predicts that 1.2% of the Vermont population, 18 to 64, has opioid use disorder. We currently have 2.7% of adults 18 to 64 on either methadone or buprenorphine. So if you're using NISDA numbers in your community, they're widely underrepresenting the number of people actually that have OUD and need treatment. So this just shows the areas in the state. And we have some areas up here, Franklin County, 4.2% of the adult population is on methadone or buprenorphine. There's no other country in the world that has that number of people per capita treatment except for the country of Iran, which has a very robust treatment network, if you didn't know. In the United States, it's somewhere around half to, in some cases, 0.1% of the adults are on buprenorphine, are on some kind of MAT. So we know that when you provide treatment, you can really increase the number of people who can access that. There was a survey done by a researcher out of UCLA looking at the hub and spoke, and basically he found that after 90 days of being in treatment, the number of opioid using days went down by 96%. The number of days of injection went down by 92%. They found that change in opiate use was significant, as evidenced by the blue before treatment and then after treatment. Significant cost savings. I mean, I know that I'm not talking to state authorities, but when we present to state authorities, we show that there was in 1 year a 7% savings in medical costs in 1 year after establishing the hub and spoke. People who were in treatment started costing significantly less in terms of the medical care that they were provided. Number of ED visits dropped by almost 90%. Overdoses in the previous 90 days dropped 100%, and illegal activity and arrest dropped by 90%. So we just know that what it brings to the community overall is savings in cost, in health, and community benevolence. The other thing is that in Vermont, Act 176 was passed 4 years ago, and it mandated that if you were an opioid user, you needed to be evaluated for both initiation or continuation of medication of either methadone, buprenorphine, or naltrexone. And so what we do is we have people who are coming into the criminal justice system, either maintained or started, and then on discharge, they go directly to the hub or the spoke the very next day. So we've cut our overdose rate down by about 70% at 6 months in people that are initiated in or maintained. And then lastly, this shows in Chittenden County, which is the largest county in the state, the overdose rate was really, really rising and then significantly dropping over time. And that was with a significant expansion of treatment in our town. So that's the end of my slides. And if I could just sort of sum it by saying, the real advantages are the collaboration. I think what I've seen over time is that a lot of docs, a lot of people, providers were uncomfortable treating opioid use disorder. I was uncomfortable treating hepatitis C, and now I'm very comfortable treating it because I had mentors in the community. I had resources in different specialty departments that guided me along, and protocols were created so that I can, even me, a regular family practice doctor, can treat hepatitis C. So I like to think that with a robust network of addiction providers who are involved with hubs, helping spoke providers who are not as skilled or knowledgeable, you can really create a nice integrated system where you can expand treatment and really help people stay alive.
Well, thank you, Dr. Brooklyn. We do have some time for questions. So if you feel more comfortable putting them in the chat, that's fine. If you want to unmute and ask your question directly, that is fine as well.
Yes, I'm happy to answer any questions.
Yes, Lori?
Yeah, Dr. Brooklyn, every time I hear what's happening in Vermont, I just am filled with so much hope. It's just incredible how treatment has become so accessible in your state. And I just applaud you and your colleagues for making that happen. I was wondering if you could talk more about the justice involvement in the transition to the hub and spoke. And is that a warm handoff? Is it something that starts before the release of the individual actually happens, so they're prepped as far as what's going to come as far as supports and assistance? I would just like to hear more about that. Thank you.
Yes. So just to help you understand the landscape in Vermont, we only have state prisons. And believe it or not, each prison is located in a county in which a hub exists. So they're all linked in many ways. So as I pointed out in the map, so if you're in Franklin County, the prison there, if you're incarcerated there, you would, upon release, most likely come to the hub in that community. But if you were, say, going back to Chittenden County, you'd be released there. So typically there's not a lot of planning. we usually get notification ahead of time, but many times people appear before a judge on a Friday and the judge says, you can leave, and they walk out the door. So there's not the opportunity for that planning, but they're given, or we're faxed a last dose letter to know what the last dose was if they're on methadone. Many people in the community have buprenorphine prescribers. And if they don't have a buprenorphine prescriber beforehand, they're referred to the hub, or they're referred to some of the community providers that exist. And many times an appointment's made on discharge, or DOC will provide them with enough buprenorphine for a week so that it gives them the time to get in. Because of the lack of a waiting list, it's very easy for people to access treatment. So I would say that it's not as robust and as sophisticated as you would like it to be, but the insurance gets reactivated right away, so that's not a barrier. They can go to the hub or the spokes in their community. You can walk in and get treatment that day, so that's not a barrier. And if we don't have a letter, we can call the correctional facility and find out that day, because we have contacts with them all the time to say, when was the last time this person was dosed and how much was it? And then we continue that. We continue with that on intake. So we do really try to make it just on demand. There was a question in the chat, let me see, from Richard Taylor. Okay, what tools are your nurses or social workers using to help manage their caseload of 100 patients for the program? Great question. So in my experience, because I work at two different spokes, one at an FQHC and one actually embedded in a hub, is that the nurses typically will handle the medication, drug screening aspect of things, but also help with other things such as, hepatitis C coordination. If people are diabetic or hypertensive, they'll sometimes have them come in for those visits. But the behavioralists, they have kind of a mandatory check-in once a month with the individual. They'll call the person up just to let them know that they're available. In some cases, they actually provide some brief counseling. In fact, at one time I had a program where my clinician would meet in groups with individuals, and he would do things like financial planning and what to do around the holidays and how do you manage a job interview and things of that. So it's just a life skill opportunities. And we have a bit of a manual for that. But essentially, over a month's time, they would make contact with someone at least once. And if there was an issue that the person needed help with, they would schedule an appointment or do it over the phone or meet the person outside to kind of arrange that. And so there was no kind of time limit. They weren't really able to do in-depth counseling where you're meeting with somebody to deal with things on a weekly basis, but they were able to refer people if they needed more counseling. Let's say there was some significant anxiety or depression and they thought that they needed some additional help. But there was no, and we use a spreadsheet to manage our folks just to find out when they're due for prescriptions, when we last saw them. I mean, I use a pretty simple Excel spreadsheet with my nurse and clinical person, so we can manage it in that way. We're fairly structured in terms of knowing when people are coming in. We have them come in typically on the day that they're due to get their prescription, so our no-show rate is quite low. But in terms of keeping track of the individuals have their own strategies for doing that. And you're right, for 100 people, it seems like a lot, but over a 30-day period, it doesn't amount to as much as it does. And then the next question was from Pierce Story. Does Vermont utilize any kind of software to help manage patients? I heard you mention faxes. Yes. So all the programs have electronic medical records, but the electronic medical records don't necessarily communicate with each other. So for instance, one of the hospitals I work with, it has Epic. My community health center has NextGen. One of the other hubs I work at has Credible. Another one has their own system. So they're not really integrated in that way. And actually, because of HIPAA, it would be difficult. But one way that we get around, and this was a state mandate, is that when you come into treatment at either a spoke or a hub, you need to sign a consent form for us to communicate with your primary care provider if you have one. And the reason for that is that if you're coming into a hub and you're getting put on methadone, we want the community provider to know that you're on methadone or you're on buprenorphine because of potential medication interactions. You can't check in your PDMP that the person's on methadone or buprenorphine if they're at an OTP, because those are closed systems. You can only detect if someone's on buprenorphine through a pharmacy. And so we think it's very important for that to happen. And it's very, very rare for someone to refuse to do it. And that collaboration, every single month, we send a letter to the primary saying your person is on such and such a dose. This is how many take homes they do. Please let us know if there's any medications that you're going to start them on or interactions. So we do have a lot of that kind of back and forth, but it's typically more faxes because medicine somehow hasn't caught up to the rest of the world. We're still faxing stuff left and right, as opposed to sending it electronically. So in terms of the management of it, each EMR is different. We are all mandated to check the PDMP on intake at a hub, and we check it quarterly so we can stay abreast. And in the spokes, people are supposed to check quarterly also. So it feels like there's enough collaboration in each area. And then the spoke staff, those MAT teams, they meet on a monthly basis in each county. Each county has a monthly MAT team meeting, and you might have 5 or 6 MAT teams. And so you have the ability to coordinate care and share information with each other at that time too. So it tends to be, well, it was in person, now it's remote, but it tends to be a lot of that community collaboration that does help.
Great. Does anybody else have questions for Dr. Brooklyn? Sorry if there's some background noise. I am on a college campus and it sounds like class just got out. All right. Well, if anybody decides they have any questions for Dr. Brooklyn, then we can answer those after the next part of the program. And
Can I
we
just
will
ask one more, Jennifer, since
Of
nobody
course.
else has a question?
Of course.
Could you speak to if there are differences in how pregnant women are handled in your system?
So as mentioned earlier, we do have a statewide initiative called CHARM, and CHARM actually is in Chittenden County, which is the largest county, but all counties now have a similar thing. And CHARM is basically Children and Recovering Mothers. It's an acronym, and it's a community team. It's an impaneled community team where you have the obstetrical service that's caring for the individual. You have the neo-medical service that's going to be taking care of the infant. You have the addiction service that's working with the mother or the family. And then you have other resources. Actually, our Department of Children and Family sends a representative so that we can be supportive of the families during this time and not necessarily there to remove children from parents' care. Public health nursing. So we have that collaboration in each county, and those teams meet monthly. Most of the time, and in fact, our hospitals also have a lot of the OBs are buprenorphine waiver prescribers. So we have a lot of women getting buprenorphine from their OBs, or if they're on methadone, they're getting it from the hub. But we have consent forms that we sign, and we have collaboration back and forth with treatment and the OB providers so that we can make sure that women have healthy pregnancies and healthy outcomes. And we have very low DCF involvement because of that. And in fact, if someone is using during their pregnancy and not able to become abstinent, we still bring DCF in early so that they can be a help and not a hindrance at delivery. And many times they really are trying and working hard with families to kind of keep them intact. So the coordination is kind of top to bottom between OB medicine, neo-medicine, pediatrics, and addiction medicine, psychiatry if need be, and all the public health resources that are necessary to really maintain healthy pregnancies.
Dr. Brooklyn, has that had an impact on your NAS or NOWS?
It has, in the sense that we are very familiar with NAS at all the hospitals in the state. In fact, the hospitals in the state no longer transfer to the tertiary care hospitals. All the community hospitals can deal with NAS. And as you know, NAS is kind of independent of use. We know that with methadone, we really try to get people on stable doses of methadone so that NAS is reduced. Buprenorphine is less likely to cause NAS. But what we don't have is we don't have a lot of surprise pregnancies where we're suddenly finding out that NAS exists. It's really unusual to not identify a woman during her pregnancy who has an opioid use disorder because we have treatment on demand and we really focus on getting people into treatment. Before this ever started, we had a tremendous number of women who were delivering who we had no idea, but once we started to have a network, the incidence of unknown or unplanned NAS is very, very low. But obviously, it's still a situation that occurs in the opioid exposed infant.
Thank you so much.
You're welcome.
All right, thank you for telling us all about the amazing work that you guys are doing up there. Again, if we have any other questions that come up for Dr. Brooklyn, we can address those later. We are now going to do a panel. We're going to have 3 speakers. Each will present for 10 minutes. At the end of the 3 speakers, we will have some time for Q&A to ask all of them questions. So our first panelist is Christina Cupp. Ms. Cupp is Spirit's product manager. She's a certified product owner. She partners with the SaaS product team to analyze and evaluate user needs and software requirements to determine feasibility of design within time and cost constraints. She validates customer needs and communicates software system design and maintenance to ensure success. She helps Spirit's community partners get up and running and ensures excellent service, support, and training. She is going to be providing us with an overview of Spirit software. Christina?
Thank you, Jennifer. And I'm going to do a very brief demonstration, and I'm going to touch upon the basics of what you can do with Spirit. Let's get my things started here. Let me share my screen. Jennifer, can you see my screen okay?
Yes, we sure can.
Awesome. So what is Spirit? It stands for Suppression Prevention Intervention Referral Intelligence Tool. It is a secure, collaborative, web-based platform that's accessed through roles and permissions. It is a client-focused case management toolset that is powered by a real-time matching and referral system to properly link clients with your vetted providers that are set up inside Spirit. It was created for use on PCs, tablets, and handheld devices. You just need access to the internet or a mobile hotspot. We have different ways to set up your organizations in Spirit. You can simply be an agency. It could be the main agency or a hub. You would just create clients and use the case management toolset and a referral feature to find services for your client. Or you can simply be a provider who creates the service and then you accept clients for those services you created. And you could also use the referral feature to find additional services for your client. But you also, as a provider, you can use our case management toolset, or you can continue to use your own system. We just ask you simply log in to accept the client, maybe manage your services, and you would probably be notified of any type of case notes. You also can be both. You can be an agency and a provider. In this case, you can create your own clients and offer services. You can use the referral feature to find services for your clients or use it for internal referrals for tracking purposes. But all features are available to use regardless of how we set you up in Spirit. And you also can add as many users as you wish. We also offer training. We also work with you to create and set up your organization in Spirit to match your current workflow and train you how to use the system. And we offer a help section with videos and PDFs and on-screen guidance. And again, we're always available with you if you ever start using it and you get stuck. And our goal again is to help you and your organization be successful while you're using Spirit. So the basics of Spirit as an agency is you create a client, and that also can be set up as an intake page as well. And then we can create a case and find services. So of course, the first thing, once you're logged into Spirit, you would add a new client. And when you are creating clients or cases, you can customize your own fields. This can be accomplished on your own with a manage field tool or with our help. Usually in the beginning, we help set you up, make sure that any data you are required to capture, we'll make sure those fields are in there from the start, so that way you can report on that data. Fields can also be marked mandatory, so we can make sure that you do capture that data when creating clients. Once a client is created, a client view page displays the information that was collected while you created the client. And you could add client notes, add documents to the client level, and also add household members. So you're able to find services for the additional household members as well. This is usually where the non-sensitive information would go on our client view page. To add the sensitive information and to also access the referral section, you would add a case. These are just examples of some fields you can create, text fields, a larger text area field. We can do yes or no's, drop downs, check boxes, and date and time. And we're also just offered a total section where you can actually put and gather items such as rent and mortgage, and it'll give you a total. So once you create the case fields, that becomes the case info. And then once you create a case, you have access to the case management toolset where you can create appointments. We can work with you to build out assessment or questionnaires. You can add case notes and case documents. And this is also where we would create a referral as well. With a referral, when you create one, you get a visual service mapping. So you would be able to see all the different areas on the map where the providers are located. So if your client does have transportation issues, or you also just want to search a certain part of the city, you would be able to do this to help you locate what you need. You'd also would select any issues for your clients if you didn't do it prior to the referral. And you could also look for more than one issue for the client as well. But on this page, what happens is after you do a few refining, then this result shows the best matches available for the client. When we do create services in Spirit, we gather details on age and gender and language, interest, issues, and location. So if a service is for females over 18, then that would not show up for your client if your client is male or a female who's under 18. You can also select details to see more information about the service that is showing on the screen. And you can select multiple referrals here if they were available. So for instance, if you had one issue for counseling and another for job assistance, you could select both of those and make more than one referral at this step. You also can decide how much time you'd like to give the provider time to respond to the referral. So that can go anywhere from 24 hours to 2 weeks. And you could provide notes for the provider that you'd like them to see. If you're sending this service to your own services, you can do an internal referral. You don't need a consent form because you already have access to the case. Or you can also create an authorization agreement. And I won't show you the whole document, but it's all pre-filled in for you. And it covers all the bases of your client information. It is an electronic consent form. They can check a box and sign the screen with a mouse if you're on a PC, or a tablet with a stylus, or your phone with a finger. And if you already have consent forms in place, there's an option to just do verbal and the case manager can sign it. But we can work with you if you have a different consent form in place. But we do have an electronic one, which allows the provider access to the case details. So once you've sent the referral, on the case level, you'll be able to see the status. And as soon as the provider accepts it, you would go from pending to assigned. You could also, there's other places you can see the status of all the referrals you've sent. And we have notifications that you can turn on and off. So you can be notified outside of Spirit if the referral you sent was accepted, denied, or if the provider is asking for more information. So as a provider, your main function, you create a service. You can have one service, you can have many services, you can maintain those. And then once you create the service, then you would then get referrals and accept the client for the services you created. But you also have an additional option to find additional services for your client using Spirit. So again, when we create the services, you can break it down to specifics to aid in our matching. So again, if you have a male only or a certain maybe it's all genders, but it's a 14 to 18, you can break it down that way. And you can also come in here and limit how many referrals you can accept. So if you only want to accept 5, you can put in a number, and then Spirit will automatically waitlist it once you've received 5 referrals. So we have a lot of options. We can set up your services. You can also waitlist the service yourself at any time by turning it off. Maybe you ran out of room for whatever your service was, or you would just want to put it on hold until you're ready to turn it on. That power is all yours. You can log in and turn them on and off at any time. So when a referral is sent to you, you'll get notified by email and text, depending on your notifications. But also once you log into Spirit, you'll see the notification. Again, you'll have the option to accept, deny, or ask for more information. Because a consent form was signed by the client, you'll have access to the client contact and case information to make an informed decision. And then if you do ever ask for more information, that does become an automatic case note inside Spirit. And again, if your notifications are turned on, you'd be notified that the provider you sent the referral to is asking for more information. We have notifications that we consider them live, are active. You can click on it. And then when you click on the notification, it takes you directly to the case notes, so you don't have to search for it. And then you can have a communication back and forth. But this way, the provider can let the person who sent the referral know that they're having trouble contacting the client, or maybe they have a couple questions from what was put on the client details. But at least become a history of that information and we'll understand. And then if they do deny the referral, they have to say why, and that also becomes a note inside the system. So as a creator of the client, you can see when the referral is accepted and communicate with the provider while the client is being helped. You can share client and case notes with each other, or you could also mark notes private if you do want to just keep them internal. The agency and provider will be able to both pull reports on the client's demographic, customized fields, and referral information. You can use Spirit to message the other agencies and providers that exist inside of Spirit. And you can view all services available for your client. Even before you make the referral, you can see a list of services that currently exist. And we also offer a Spirit client portal that allows the client to communicate back and forth with the agency and provider. They can't change any information in their provider, but they can take assessments, they can upload documents and request changes. And lastly, just about your data, you can pull reports from the raw data from our reporting tool. This has all the core fields, the customized fields you add, as well as timestamps. For example, when referrals are sent and received, or cases are opened or closed. And you could also email the reports to multiple parties, and you can download them with the 4 options. It is very customizable with the type of report you want to build, because it basically has all your fields. You can pick and choose, line them up, filter and sort as well. There's also a bird's eye view dashboard. And this will just basically these are just a few examples, but you can see your total clients, how many have open cases, closed cases, what's the top referrals that have been sent, like who our main players are. And again, just example of another thing that's on the dashboard for referrals and even the demographics. And we have an additional step where you can hit view to just see who these 19% females are. And you could also filter too to say, just show me the females that are in a certain zip code or a certain age. So you can break it down as well. And again, we have a help section feature on the bottom. We have keywords attached to certain stuff. So for example, if you typed in data, it would pull up a PDF that shows you how to get your data from reporting or the dashboard, or there's a few other places as well. But again, you can type in keywords. You can also scroll through. And we also have a submit feedback button when you use the system to ask for help as well. Again, this was a nice little short demonstration. There are additional features I'm not able to go over, but just to let you know that we do have a service grant tracking that we can tie to services, as well as an invoice feature as well. And that concludes my 10 minutes.
Wonderful. Thank you, Christina. Does anybody have questions for Christina about Spirit Solutions? Okay, we're going to go right into, we'll have time for Q&A at the end. We're going to go right into our next speaker then, who is Jason Goodman. He's a certified peer recovery specialist and the director of recovery support services for Metro Drug Coalition in Knox County. He is responsible for the oversight of MDC's peer recovery staff and recovery initiatives, which will help lay the foundation for other support activities planned as the Gateway Community Center becomes operational. Mr. Goodman will be speaking about MDC's experience with using Spirit software. Jason?
Everybody hear me okay?
We can.
All right, good. So good afternoon. Thank you, Jennifer and Lori, for putting this together and for everybody who's participating. Thank you to the doctor and to Christina for their presentation so far. I've learned a lot of stuff already. So just a real quick backstory. We held a community-based meeting, brought together most of the major treatment providers several years ago. MDC hosted that event. And the whole idea behind the event was to talk about creating a hub and spoke model of care for folks who had addictive issues in this region of Tennessee. So in Knox County and the 15 surrounding counties of Region 2 through the Tennessee Department of Mental Health and Substance Abuse Services. So as we're hosting that meeting and all the ideas are getting thrown out there, the whole purpose was to drive home the importance of hub and spoke, how it had worked in these other areas, and how we could fix some of the problems that we were experiencing in this region about folks accessing services. We wanted to zero in on who should be the hub, what that should look like, and then how do we operate that hub and spoke and bring everybody together. So what we did not know going into that meeting was that everyone there was going to basically turn around and point back at us and say, we think MDC should be that hub, mainly because of our neutrality in the community, in the work that we do, and a lot of it being the stakeholders that were already at the table with MDC. Everyone thought that would be a great way to start the operation, would be MDC become that hub and then add in all the spokes in the community. As the meeting progressed, the idea became make that twofold: a brick and mortar location to serve as that physical hub, not being treatment. You know, I appreciate the doctor and his presentation, and those models that we've looked at were around, most of that was around an MOU provider, and then the spokes being the wraparound services that were needed. We were talking about a little different approach, just a neutral space where folks could come in seeking addiction treatment, sober living, long-term recovery support in the form of coaching, peer support, whatever that looked like for them, recovery meetings. Just how could anybody, not necessarily substance specific, but how could anybody experiencing addiction issues and even families come into a physical hub and look for a way to connect to what they needed to either initiate or sustain long-term recovery. So we decided to start looking at a physical space for that to happen, which has turned into the Gateway Recovery Community Center project that will hopefully be open. At least 80% of that community center should be open sometime this summer. We're just waiting on a main distribution electrical panel to come in to complete phase 1 of construction there. Big project. I would love for any of you that are interested to come see that space. So the physical hub is on its way, but we've had the second portion being software as a hub. And the group thought you can go ahead and purchase software now and start adding providers in those wraparound services now. So start demoing software and looking for a physical space. So we were doing both at the same time. So we demoed many different software platforms, and we zeroed in on Spirit for many reasons. Part of it being our idea was that these would not be medical professionals or treatment providers in this hub that would be operating this system at MDC and some of these other surrounding agencies. Some of this could be folks who are just peer support specialists who don't necessarily have a ton of skills around computers, office skills, any of that stuff. So we were looking for the most user-friendly, and we found that in Spirit. We also found their mission to be, it resonated with us, why they were doing the work, the reason why they got involved to start with, and some of the history that they had in other parts of this country, doing very similar things. And results, outcomes, the outcomes were great utilizing their system. So they offered to give the software to MDC at a very reduced rate and not charge any user a fee to use this system. So any provider that chose any wraparound service, anybody that wanted to sign into our system, there would not be a cost to them to use it. We still stand under that same agreement with Spirit now. We have that software platform. What we have done is, I can tell you this, the hub is only as good as the spokes, and the more spokes that are involved, the better the whole thing operates. We had some interest out of the gate from some of the providers in our community, but we had more disinterest than we had interest. So what we really need is for folks to sign into the system to make it more effective, simply for that reason. It operates better the more people that are in it. So we have the software platform now. We've had it for some time. What MDC is doing with it currently is we use that for our recovery support team, uses that for our internal program of record. Everything that we're doing, every service that we're providing, every housing deposit that we're paying, every treatment referral we're making, every coaching client that we bring into MDC, all that stuff is in our system now. We're gathering data, we're seeing outcomes. It's how we do everything on the recovery support side. It's capable of doing many other things. It's capable of billing. It's capable of making and receiving referrals. I think that it may take a little better hold once we're in the physical space and more people are attached to us there around what we'll be doing out of the gateway. It may, the participation may increase then, but again, the software, we have it now. We believe in it. We believe it's very capable of doing anything that we would want to plug into it to make it more effective. To be truthful, we led with the idea that this is going to change how we make referrals to addiction treatment because we struggle with that. The doctor said Tennessee's not a Medicaid expansion state. Most of the folks that call MDC for treatment, for detox, don't have insurance. So we go through this process every day of making hundreds of phone calls trying to find a bed for somebody to get in treatment. And then if they do get that bed, we never know if they arrive or not. We don't close that loop. And we don't connect with those detox places a lot of times to further that person's recovery process out the other end. This system is capable of doing all that. So what we're going to do very soon is move into this physical space, and we're going to use this software platform to gather data there as well. Everybody that comes into the gateway going forward, they're going to check into that system at the door and say what they're there for. And we're either going to use that system to make referrals, or we're going to, with your participation, with some of the providers' participation, we'll be able to do that, or we're going to keep making these hundreds of phone calls we make every day. And we're going to keep doing that if we have to. But we believe that this system could change the game around how we communicate with each other when it comes to providing services. One thing that could happen with this system that I believe is most beneficial to this entire coalition of people who want to make a change is that every provider in Region 2 in Tennessee, period, could enter their information into this system, and we could have an alive and breathing clearinghouse of what services are in the community, because that's something we struggle with for sure. I don't know that everybody's going to want to make and receive referrals with this system. I don't know if everybody's going to want to use it for case management or billing, but what can happen is we can have that. Every meeting I go to, people want a list of what resources are in the community, and that list is as good as the day you print it, because it changes the next day. But what this system is able to do is daily, hourly, on the minute, a provider can go in and change their bed availability. They can change their, if they get a new grant and they provide new services, all that stuff can be alive in this system. And when someone comes in to that hub or into your service and says, hey, we have an issue here, we're looking for this service, you can enter that information into Spirit, and it will show you the closest provider, the provider that is the greatest fit for the need. So I think this could be an alive and breathing resource of what services are in the community. I think that's what we should have led with, and not so much about changing the referral game, because we didn't get a good response from that. A lot of people told me we don't want to receive referrals this way. And then the odd thing was, when I asked them how they were receiving referrals now, they would tell me things like, we do it via fax. And I was like, well, that doesn't sound too secure, and it doesn't sound like a very technologically advanced way to receive a referral for care, but that's some of the responses we got. So Spirit has worked well for us for what we've done with it so far, and we believe it's capable of doing many other things. If you're interested in taking a look at the system further, I know Christina is willing to do a further demo for folks that are interested. Set up your own portal, and you're more than welcome to sign into this process with MDC. And that looks like an agreement that says we're all going to abide by HIPAA, basically. And if there's any other questions, Jennifer, that's my short spiel for now. If somebody has a question for me, I'd be more than willing to answer it.
Yeah, let's go ahead and do one or two of these questions. Lori asked, how long has MDC been working with Spirit, and has it evolved over time?
Yeah, we've been with Spirit for a couple of years now. And has it evolved? No. The process has not evolved for us, because again, it takes, we had the funds at MDC and we had the idea. What we did not have was supporting funds to get out in the community and make it happen. Because this takes a lot of effort to get out in front of people and say, we want you to sign into a new software system. And we were kind of doing that bootstrapped on our own. Again, twofold. We were trying to open a physical location, which turned into a $3.25 million project, at the same time that we were trying to get this software platform up and running. So it has, I would not say that it has evolved over time. No, the only change has been, and Alora could tell you about this, is some of the work that Alora Pritchard and those folks have done in Claiborne County. They've utilized this software to do some things there, but that hasn't necessarily attached back into the hub for us. So we just shifted gears and started using it as our internal program of record. We have some plans for it internally for MDC, but we keep it open to anybody who might want to help us evolve this idea in the community. I hope that answers your question.
Wonderful. Thank you, Jason. We do have a couple more questions, but I think Christina and then possibly you or Dr. Brooke want to answer the other. So let's hear from Laura, and then we'll go back and get to the rest of the questions. Alora Pritchard is a person in long-term recovery. She's a licensed master social worker who is working with Servolution Health Services through the University of Tennessee's Project Now. She's also a member of the board of directors for Live Free Claiborne, a nonprofit with the mission to support wellness and eliminate addiction to drugs and alcohol in Claiborne County. She will be speaking about Claiborne County successes and the use of Spirit at Servolution Health Services. Alora?
Thank you, Jennifer. I appreciate being with you all today from Claiborne County, Tennessee. It's definitely been a great year for connectivity here in Claiborne County. In rural areas, we often have a hard time connecting with one another. And, you can go to meetings where other services, but it's like everyone is not able to be on the same page and saying we need to know what each other is doing. And so that has really been the attitude over the last year. And so I'm going to talk about Spirit and kind of how that just kind of manifested right when we needed it and how we have successfully implemented it. And then also our hopes for what comes next. So we were approached by Lori with Now and Jason with MDC with this opportunity. It was in September of 2021, and we implemented it in Claiborne County. Servolution, Live Free, and our Family Justice Center. These are all nonprofits here in Claiborne County. And these are our 3 success stories of who have latched on to Spirit and is using it as a way to connect to one another. And so I was just going to tell you a little bit about the feedback that I received from the Family Justice Center and Live Free. So Live Free is works with substance use disorder. And, you know, Jason said we're not tied back to the hub, but I want to put the word yet on that. We're very excited to be using this software, and we know that it will just continue to develop. So hopefully that is one of the things that's going to start moving, is that connectivity. So when I reached out to Susan Stone, the executive director of Live Free, and just asked for some feedback on Spirit, she said that she has appreciated the ability to run reports for statistics, and that you can export it directly to an Excel spreadsheet. The referral process, Live Free has been utilizing that. And then access to information, that information sharing that happens when a referral happens, but also internally. I get to go work at Live Free 1 day a week, and internally you have different people in the offices doing client management and having access to that information. And she said also the client management database. And I know that we are just lucky on this, that MDC came to us and has allowed us to be a part of this, because for a rural area, especially here in Claiborne County, we do not have like crowdfunding. We don't have direct lines of funding for our nonprofits here. And so that's a struggle for being able to spend that money that it takes to get set up in a client management software, especially for our Live Free, who is a newer nonprofit. And then our Family Justice Center is also a newer nonprofit. And so the Family Justice Center helps our individuals who have experienced domestic violence. They work in the county center. They are there with our legislators involved in the court, and it's a very good connection to have, because a lot of the times, even if someone's not involved in a domestic violence situation, they will go there and say, where can I get help? So it's phenomenal to have them in the Spirit. So I reached out to Bobby Womack, that's the director at the Family Justice Center here in Claiborne County. And I just wanted to read her whole email because I thought, well, she said that perfectly. So I'm just going to read that to you. She said, Spirit has been amazing for us at the FJC for multiple reasons. First off, the cost of a client database was astronomical. And while we had budgeted for it, being able to use Spirit has allowed us to use that money in our FJC budget to purchase other things we need for victim services that we would have done without if we had to purchase a client database on our own. Secondly, Spirit has allowed us to move toward a paperless tracking system to save storage space in the FJC. We realized very early on that we were going to struggle with storing case files after cases closed because of the high volume of cases we have and the lack of storage space in the building. We are now uploading all documents into Spirit, which makes it more easily accessible, and we don't have to have the worry of storing paper files. And lastly, sending and receiving referrals from partner agencies is so easy through Spirit. Being able to make and receive referrals in one centralized location helps us ensure we do not let anything slip through the cracks. We believe in working smarter and not harder at the FJC, and Spirit has definitely made our data tracking process much easier and more effective. And I think that really sums up what Spirit has meant to our nonprofits here in Claiborne County. Again, being in a rural area and having this system, this opportunity to be able to even be linked to MDC now, because again, our attitudes and focus here in Claiborne County are shifting, and a lot of them are pointed towards substance use disorder, where before You know, it might be one or two agencies who are really trying to lead that, but now everyone is recognizing it as a health crisis. And so more people are getting on board. And so I really feel like this is giving us a couple feet ahead. So when it comes time that more collaboration is happening, we're going to be able to utilize what we already know as far as making referrals in Spirit. And because, so Servolution, we have counseling for individuals who are uninsured. And then again, like I said, the Family Justice Center is for our individuals with domestic violence. Because we have services that are so vital for our area, the interest of our bigger organizations of using Spirit and being able to just make a referral because they've seen someone else do it or have heard about it because we're all kind of close here, has really sparked the interest at the McNabb Center, and then also at CHET, which is Community Health of East Tennessee. And again, they do a lot of stuff, but with the domestic violence individuals who have experienced domestic violence, that's really where we kind of come together and have a shelter. So they have both expressed interest in being on maybe the receiving and referring end, but those have not went all the way through because there's a chain of command that kind of happens, but still just being able to spark that interest and know that probably if we spent some time there, that might be something that could happen. And so just to end with the areas that we hope to grow into, we hope to make more connections because we have it at Servolution, Family Justice Center, and Live Free, and these have really been our places that we've been utilizing it and having success. And now I feel like we kind of really understand it and can take it more out there. And we want to be able to take out the guesswork for new users because Spirit has a lot that it can do. And that's why it's so great and it's customizable. But here in Claiborne County, like, people think I'm a technical genius and I'm not at all. So it can be overwhelming depending on who is using it. But like Christina said, they have great customer service. And so just being able to really lean into that, like Jason said, it takes time to develop, to have energy to put into that, developing the relationship and helping them get set up in the Spirit also. And then, you know, we just want to continue helping our recovery coaches. We want to get them into Spirit so then they feel like they're linked up and our agencies can send referrals, and our recovery coaches have the support of knowing that they have agency help and can look in Spirit and get our information and reach out and even be more supportive to their person that they're doing coaching with. And so that's really where we hope to expand. And so, yeah, thank you for having us. And I'll be happy to answer any questions.
Thank you very much, Alora. We do have a couple questions in the chat. This first one's from Pierce. It might be for Christina, but can Spirit push-pull data from or to hospital or PCP EMRs, or have you found that to be necessary?
We can, if you have an open API, then we can push data to it. We don't currently have an API, but we can create one that's specific to be able to pull data from. And it's something that can be set up to run nightly or daily or weekly, but it's something we can build. And I know we can work with open APIs.
What does API stand for, Christina?
I have to look that up. It's always just an API to me. It is a way to basically get two things to talk and be able to send data. Okay. So that way you're not having to do a duplicate entry. It's basically you enter it in one database and then it just basically auto-populates into the fields in Spirit,
I
or
see.
vice versa.
Okay.
And I think it depends on which EMR you use. We use Athena, and I think Christina and I both, we tried to get that to work with Athena, and it ended up not being able to work with Athena. But I think it's just kind of particular to which EMR you use.
Yeah, because there are some companies that are like, no, we have a closed API. You can't have access. So, but
Gotcha.
it does
Okay.
stand for Application Programming Interface.
All right. See, that's not any more clear to me than API.
Right.
So
It's basically a bridge. You
gotcha.
can go one way, go the other.
I see. And then Pierce also had another question to Jason or Dr. Brooklyn. Do you routinely try to find insurance or financial coverage for patients? That could take a lot of time and effort. Just wondering if that's something that you have to or need to do. If so, have you tried to automate that? So Jason or Dr. Brooklyn, whoever would like to take a stab at that one.
Well, for us in Vermont, because we're Medicaid expansion, it's very unusual for someone not to qualify for insurance. And if they don't qualify for insurance, we have some federal grants that will pay for treatment. In the spokes, there are people who make too much money, obviously, to qualify for Medicaid and not enough money to be able to pay for commercial insurance. So they pay out of pocket. But at a lot of the FQHCs, we try to find sliding fee scale situations for them, and even what we call these 340B pharmacy programs where people can get medication at reduced cost. But sometimes we resort even to things like GoodRx. So we try to be as creative as we can, but we do have a fairly good safety net. One of the bigger issues we actually run into is that a lot of people have very high deductibles. They have insurance, but they have high deductibles, and that becomes a different set of challenges than people who don't have insurance. But back in the day, before we had this kind of insurance coverage, yes, we spent a lot of time trying to figure out who could take what. And there are some programs. I know that there's a program out of Colorado called OpiSafe, and they actually have a data bank where they enter all the providers in the community. And in Colorado, I think your driver's license may have a chip embedded that will tell what kind of insurance you have, or you can get some kind of a card that'll tell what kind of insurance you have. So there's a way of flashing the card, and it will tell you whether your insurance is actually covered at that site. So there are a variety of ways that people have gotten creative with it. But I have to say, coming from the bubble of Vermont where many things are covered, we don't encounter it probably as often as you do.
And we have the opposite story here. It's pretty uncommon if you qualify for insurance here, if you don't have it in Tennessee. And wrap your head around this one. The people that find it hardest to get on insurance is the demographic of gender and age that we see dying from overdose the most in our community right now. So it's directly the opposite for us. So the people that contact us are looking for detox or some form of support. We try to find grant funded support for them via treatment, coaching. We pay deposits into sober living. So we try to spend time coming up with low barrier access for those folks. We don't spend very much time at all. Matter of fact, I've never tried to get anybody signed up on an insurance policy. Just made people aware of what is available to them. Situations like someone who is currently using drugs and pregnant, to walk into an OBGYN or the ER and pretty much become eligible for TennCare right then. Situations like that, we spend some time around, but other than that, no.
All right, thank you both. And then Lori had a question. Oftentimes funders differ in the reports that they want. Is it possible to create custom reports for different funders that could be scheduled to be created as needed?
Yeah, and we also have ways to do customized reports, because basically when you get to the reporting, you can decide, you pick all the fields, you can rearrange them. You can even say, I like this format, and set it up to be reoccurring, to come daily, monthly, weekly, or yearly. There's also, if there's specific reports that cannot be run just in that format, we work with you to build a report and we could build it to be emailed at a certain time frame as well. So as long as we have the time in advance to build a specific report that the system can't do, but we can do that.
Okay, thank you. Any other questions for any of our speakers today? Okay, then I am going to turn it back over to Lori.
Many thanks again to everybody who presented today. It's been really useful not only to see where we could go with the hub and spoke model, but also to now see the tools and how they've been implemented both from the hub and the spoke perspective. I am really hoping that now we can do some breakout rooms and think a little bit more about your experience with hub and spoke, challenges that you're seeing, some of the benefits that you've drawn from it, and how you see this fitting into your work in the future. I appreciate that we're all in different places. We're working with very different organizations, but nonetheless, I think this issue of communication and doing our best to create rapid care for the people who we serve is critically important. And we all have some type of role to play in that, whether it be education at the university, direct care at a clinic, or being a peer recovery coach. So at this time, I am going to break us up into rooms. We will have 10 minutes to discuss with one another some of our reactions for today, and then we'll draw together for 10 minutes and share via the chat and verbally, ideally, some summaries about what it is that we talk through today. So with that, I will set up the breakout rooms. You will be asked to join, and then we will be coming back shortly. It may be that some people stepped away, so I am going to go ahead and hear some summaries of your conversations, things that motivated you to consider the hub and spoke model, challenges that you see. Just coming from the RCORP-ETC, we really hope that we can assist in reducing the challenges. And so having a better understanding of what those are as well would be really helpful. So could anybody start us out by sharing what your group had to discuss?
I'll jump in and talk, Lori. So, I mean, I'll just share this real quick. Marta was in our breakout room and excited to learn more about Spirit. And I think we kind of left the conversation that Jason, I'll try and get with you and maybe Laura, if we can work that in and get with Marta and maybe start setting some Spirit up in Cocke County to where we can get another spoke over in that direction connected to MDC as the hub. So I think that was to me an exciting outcome and Christine, I know that you would join in on that conversation and doing some training, which you're so fabulous at. So that was I think to me, the exciting part of our breakout room.
Excellent. And for those of you who are unaware, the faith-based community has a great impact when it comes to substance use disorder in East Tennessee. And with that, Pastor Kyle is a shining example of that. And Marta, who he referred to, Reverend Marta Cogburn of Cocke County, is another example of really bringing recovery and support into the ministry. So thank you for that share. Anyone else?
Dr. Paniszki, I do have a question. Our agency serves across all of Tennessee, and especially in the Northeast region, and then Cocke and Hamlin County. We have access to the Unite Us platform that is it sounds similar. I don't know. It's a, electronic health record that we can exchange back and forth with other agencies. And there's a large number of agencies that are participating in that. And being in Hamblin and Clark County, as well as the 8 Northeast counties, we're able to do that through a grant-based. It doesn't cost anything for us. So I guess my question is, how do we manage the multiple systems, including our own electronic health record, or how do we participate with all the different people that want us to participate in different types of platforms and make it appropriate for our various programs that are running across regions?
Could you give the spelling of that, Tammy?
Unite Us, UNITE. Yeah, Jennifer's got it.
Oh, I see. Okay.
And then it's specific to Unite Us Tennessee. Yeah.
I'd be glad to add some information on that, because we know Unite Us, we are working in Upper East Tennessee as well as Cocke County with our system. And so we are very familiar with the need to coordinate with the different systems that are being used, because we also have a referral management system that's similar to Unite Us and similar to Spirit. And so, like Helen Ross McNabb, we're working with them, and they also work in Knox County. And so it becomes an issue. I mean, I have to learn to use 5 different, referral management systems. And so it's definitely an issue that should be addressed. And certainly we have some experience in doing that in Tennessee and other states as well. But yeah, it's a good question. Good question.
Is anybody else working with Unite Us system?
So I had a meeting with Unite Us at one point a little while ago. They approached me in regards to the Sunbright School project, the University Assisted Community School. And it seemed like they might have been, and Tammy, you might be able to speak to it better. It didn't seem like more of a healthcare type of system. Maybe different types of agencies are using that one. Who's in there as of now, Tammy? Do you know?
I can only speak to what I do know. So it's a lot of nonprofits and social service agencies that have joined for this particular initiative. So I've just seen it grow in context out here over the last couple of years. And more agencies are joining that particular platform. I can't speak to it past that. I mean, we've got a lot of the substance abuse coalitions and things that are a part of that. And so I'm just trying to navigate and figure out how to do all of them, or which ones are more beneficial, and especially for those agencies that are statewide or have programs running, even the same program in multiple regions. So I have the same program that serves in Northeast as well as would serve in the area where people would be using Spirit. How do I manage that, I guess, is my question.
Christina, do you have anything else to say in relation to that?
Well, I was just going to say it might also just depend on what data needs to be collected. I don't know with Unite Us whether if it's a competitor or not. I haven't looked them up, but I know like within Spirit, once a client's already exist inside Spirit, especially like within the MDC bubble, that we do have client matching that prevents duplication from entry, stuff like that. And you can request access to say, oh, yeah, I see this other agency created a client. As far as the multiple systems, I mean, I do understand that, because you don't want to have to sign on to numerous things. I know with as a provider, you can accept things through emails. So if you get notified that you have a referral, you can actually access it through your phone to say, yes, I'll accept them without having to necessarily log in. I mean, eventually you'd have to log in to access the client. But whatever we can do too, as far as like APIs and be able to have a system talk to each other, that was something we definitely would try to do if the other party allows us to do that.
So getting systems to speak to it one another is a challenge. Having a clear understanding about the purpose or the mission behind each of these systems seems to be a critical issue to figure out. Statewide versus region seems to be a question that we can further explore. Any other challenges or concerns or enthusiasm that came up during the breakout sessions? Okay, well, if there is anything further, Dr. Brooklyn, I was wondering if you might share one of the other crises that we are experiencing other than access to treatment is access to behavioral health care. And I was wondering if you could talk about how behavioral health is wrapped into your hub and spoke system in Vermont, and if universities are at all being helpful. I'm just thinking of our College of Social Work, for example, and that they might be able to be wrapped into such a hub and spoke system so that their interns could be providing some behavioral health support, since we're so short-staffed in the rural regions.
The clinic in Burlington, which is located right near University of Vermont, we're a nonprofit mental health agency, the Howard Center, and we routinely have interns from around the state. We even have interns from outer state that will come and train, because we've got a number of master's level clinicians on staff, but also just a wide variety. And we're open. I mean, any of the hubs, there are plenty of opportunities for people to come and train because of the nature of it. But we're challenged with the same thing. I mean, we're a rural state. During these times, it's very difficult for us to even refer to a behavioral health person if someone's in crisis. Long waiting lists. Most people are virtual, which in some ways makes it easier, but it has been a real struggle during the pandemic for the same reasons. I think before the pandemic, it was certainly not as difficult, although one interesting thing is that when you're at the hub and you're on staff, your salary is related to the entity. But when you if you're interested in being a spoke provider, your salary flows through the state. And so a lot of times the reimbursement salaries were much greater. So we had a lot of people leaving the hubs to go work in the spokes. And so we were challenged. And every time you have an opiate treatment program where you're losing staff members, it affects your ability to bring new people in because they have to have a behavioral health assessment. So I don't have any great answers or magic as to how to solve that problem. We do believe that it's a medication first model. So if you are opiate user in Vermont, we believe ultimately that it's methadone, buprenorphine, or naltrexone first. We don't really rely a lot on this concept of detox or going to a bed, because we know when you come out, you're right back in the same environment. Even if you go to a long-term sober living, the likelihood of return to use is really high in the fentanyl era. So with a medication first model, we really deliver medication and the rest of the stuff will follow. So if someone doesn't get behavioral health right away, we'll do crisis management. We'll sort of help them through the acute situation because we have that kind of staffing. But I think that changed the dynamic somewhat than if you rely heavily on a behavioral health model before you get to medication, because then people really struggle to stay committed and stay in treatment to the same extent if they're not getting medication. But our universities do tap into us as a resource, both for nursing, nurse practitioner, medical school, residency, and all the behavioral health sciences. Yeah.
Thank you so very much. With this, I'll turn it over to Dr. Torville to close out our day. Thank you again for attending our meeting.
All right, so we thank you all. I just put into the chat the evaluation link. We would appreciate it if you would complete our evaluation survey and provide us with some data. We thank all of our speakers for taking the time to be here. with us today and share your expertise with us. Lori, I think this presentation will be uploaded to our website, correct? Okay, so if you have anybody that wants to learn more about Hub and Spoke, feel free to have them watch it. And if you want to reach out to us, if you're interested in a longer demonstration, we can connect you with Christina. I think that's about it. We thank you all for taking the time to participate. I know it's a Friday afternoon, so go have a wonderful weekend, and we'll see you next time.